Hello, world. My name is Dan Wonder, and I'm a lecturer in mental health nursing. And for some reason, I've decided to do a presentation online in my home office, talking to myself, by myself once again. But I'll explain why I'm doing that in a second. So, what I'm going to present here is actually a presentation I did in Manchester in May 2024. And it's now August 2024 when I'm recording this. So it was titled Resisting Extinction and Creating a Future, the Last Stand of Mental Health Nursing. And one of the main reasons that I'm kind of recording this and putting it out now is that I've also written a paper called The Memoir of a Ghost, the Invisible Plight of Mental Health Nurse Education in the United Kingdom following the Nursing and Midwifery Council's move towards genericism. And I wrote this paper basically at the same time as I was preparing for this kind of presentation that I did sort of down in Manchester. So the presentation that I've got here and this paper are kind of companion pieces, and I'll put a link to this paper just in the description of the video as well. So these are designed to be engaged with together. So what I'm kind of going to cover in this presentation is really sort of arguing for mental health nursing. So I'm going to talk about the complicated world that we find ourselves in. Doesn't feel like it's getting any less complicated. The strange space that mental health nursing's in, the unique nature of mental health nursing, and a plea for action as well. Now, I guess I want to be clear about one thing before I go any further. When I'm arguing for mental health nursing, I'm not arguing against any other field of nursing. I'm not sort of trying to say we're better, mental health nursing's great, everyone else is rubbish. I want to be really, really, really clear about that. I have absolute utmost respect for all fields of nursing in the United Kingdom. I think all four are unique and all four are valuable. And while I'm arguing for respect for mental health nursing, I would also be arguing in the same way for all fields of nursing to be respected and their unique sort of challenges and philosophies respected as well. So to get that out of the way, just so I'm not kind of misunderstood. This will be a very imperfect ramble. I've got kind of notes in front of me and stuff, and I'll probably scramble at them just to make sure I'm not kind of forgetting to say anything, because I do want to make sure that I land quite a few points and get these across to you. So let's take a breath and just look at that. So that's the world that we live on. And just imagine us all scurrying about there somewhere. You can look down at that, and I'm talking to myself in a room, still questioning why I'm deciding to do this to myself. Now, I think there's two reasons I want us to sort of think about the world. One is to just sort of address like how complicated it feels like the world is becoming. And it's maybe something to do with the rise of technology. I mean, things like social media, we're so connected all the time. Even things like, maybe just take for granted now or just day to day, but the fact that everything needs an app, everything needs a password, everything's sort of moving online. You need to remember about 200 different passwords for different things. It feels like the world is getting more and more complicated all the time. If you look at just some kind of issues that are going on in 2024, so we've got a rise in global conflict. I mean, we've still got Russia in Ukraine. We've got conflict in Israel and Palestine. There's identity politics. I'm not going to say any more about that other than just if I say the words identity politics, people will recognize that that is an area fraught with disagreement and complexity. Cost of living crisis seems like the price of just merely existing is going up. Obviously makes it really, really difficult for people. We've got social media in the mix. I was just reading a book by Jonathan Haidt, The Anxious Generation, talking about how rise in sort of mental illness can result from increased use of sort of screen time and engaging with social media from a young age. Important that we sort of listen and think about these things. Political populism as well. So there's so much stuff on the go all the time. And I think being a human being on this planet has always been something that has created a degree of sort of angst in most people. You know what I mean? Just thinking about your meaning, your purpose, why are you alive, and then sort of your general trials and tribulations. So the second thing to think about when we're thinking about the world is that there's no single way of doing things. There's no established, this is the right way. This is what we're meant to be doing. Now, some people tend to kind of see rules, policies, laws as kind of like laws of physics. Like it can't be changed, like it's gravity. You know what I mean? It's just gravity. You can't do anything about it. But the reality is policies, rules, laws, these things are socially constructed. They're made by people, so they can be changed as well. So that's the thing to keep in mind when I'm talking about some of the places that mental health nursing is in. Then maybe we can think that actually maybe things don't need to be this way. Maybe these were kind of created by humans over time. Maybe these things can be sort of changed over time as well. So keep in mind that there is a possibility to things, and give yourself permission to imagine how things could be very different as well. So what's happening in the mental health world just now? So we've got continued contested, polarized debates around mental health, around the etiology, epidemiology and treatment. It is an area where there is aggressive disagreement about the best way to understand mental health problems and the best way to address them as well. And this continues to this day. And certainly go on X or Twitter for 10 minutes, you know what I mean, type in mental health, look at some of the kind of the comments and content that's out there. You will see very kind of polarized views, different perspectives. Certainly Twitter or X maybe doesn't give you a kind of generalizable sort of sample of what everyone in the world is thinking, but it gives you a sense that there is a lot of disagreement out there. And that makes it quite difficult to be working in that field, because we don't have an established or agreed upon paradigm. You know what I mean? It's a massively kind of contested area in many ways. The World Health Organization recognised human rights violations and coercion in mental health practice and called for care to respect rights and dignity. Now, this has been one of the biggest problems in mental health care for probably as long as there has been mental health care, and certainly at points it's difficult to argue that it feels like care, even if it might be sort of justified in any kind of number of ways. I think on that World Health Organization document, they describe mental health legislation such as the Mental Health Act as a vehicle for the violation of rights. And that's a difficult conversation to have, isn't it? Because certainly I think at some points, we, particularly people that have worked in mental health, it's maybe difficult to imagine how care might be delivered or how a person's mental health might improve, or how risk might be diminished, risk to self or risk to others might be diminished without kind of removing a person's human rights for a period of time. That said, I think sometimes this is still happening quite badly. It's maybe not managed that well. It's not communicated well with people, and people are still having very poor experiences and not necessarily feeling the benefit of that. So I think it's important that we kind of keep that in mind. That's an ongoing kind of complexity that we've got. Concern regarding the reduced life expectancy of 10 to 25 years for people with serious mental health problems. Now, of course, that's something that we need to take incredibly seriously. A lot of people with mental health problems end up having kind of comorbid physical health issues. And certainly that's one of the things that is underpinned the the Nursing Midwifery Council's changes in the sort of future nurse standards. And certainly very, very important that we do think about that, but maybe important we think about that in maybe more pragmatic ways than maybe we have done. Certainly that's my opinion on that, but it's definitely something we need to pay attention to. Something else that's quite important here now, a recent paper, Folks and Andrews argue for a prevalence inflation hypothesis due to increased mental health awareness. Now, I think the fact that we're talking more openly about mental health, we've got mental health awareness days and stuff like that, kind of a good thing in some ways, maybe not a good thing in some others. Now, what they argue is that there might be more accurate reporting of previously under-recognized symptoms because sort of maybe some of the stigma has kind of dissipated, and people maybe feel a bit more able to be open, saying I'm struggling, you know, I mean, I'm really finding this difficult. So people are maybe coming forward with things that they might not have a number of years ago. They might have felt stigmatized. They might have kept these things to themselves. So that's absolutely a good thing. That's a win. You know what I mean? We need to recognize that that's been a good thing about mental health awareness. But also, they argue, can it be a self-fulfilling prophecy where milder forms of distress are interpreted as mental health problems, actually leading to real mental health problems? So what they're saying is actually this is not necessarily that people are like mistakenly thinking that they've got diagnoses and disorders and stuff like that. It's that actually, because there is much more awareness, people are much more highly attuned to seeing their distress through this lens of mental health problems, diagnoses, disorders, etc. And because they're looking at it through that lens, it actually sort of creates problems in them. And I think, like, it's difficult to argue that we are a kind of creature that a lot of distress in terms of mental health problems can either come from the outside and come from the inside. And I know myself, I can certainly sit in a room and think about stuff, and the way that I think can actually create distress for me. So that lens that we have for looking at the world is incredibly important as well. And again, I think that's an added complexity that we get with things like social media and people being so connected now, is that are people sometimes looking through this lens, and I might feel a bit anxious, and then all of a sudden I'm thinking, I've got a disorder, I've got an anxiety disorder. And I think those two things are different. Understanding yourself as feeling anxious, maybe due to things, due to stressors that are going on in your life, maybe thinking that that's maybe a reasonably understandable thing, it makes kind of sense, or thinking I'm anxious because I think I've got this anxiety disorder, and feeling actually powerless against that. I've got this thing, there's nothing I can do about it because I've got this thing. So the way that people think about these things can be really, really difficult as well. Anything else I was wanting to say there? Yeah, so that's that sort of double-edged sword of awareness. The increased demand for mental health care, despite a lack of resources, that obviously sort of comes out of the last one as well. You know what I mean? I think that there's always been mental health problems as long as there have been human beings. But now, due to this, people having this lens, potentially more people are coming forward. I think services were already stretched, and it doesn't feel like the expectations have went down at all. I think there's still quite a high expectation for what people are wanting from mental health care, but the resources are not getting any better. And there's huge complexities with that as well. And in the mix, we've got politicians' desire for numbers, workforce flexibility, and to do things quicker and cheaper. And certainly at kind of almost 42 years old when I'm recording this, I've definitely been around the sun enough times to see that I think what most politicians seem to care about are kind of how things look and not necessarily how things actually are, and are looking for maybe these sort of quick wins of saying, oh, we're training however many more nurses, or we're doing this, not necessarily actually thinking about maybe the quality of educations or what it's like for people on the ground in these professions, but they can throw out these numbers and then they can get elected, and then they can kind of sort of do what they want until election time comes around again. Because that's what happens in a representative democracy. You have very, very little input apart from that one vote that you cast every 4 years. So in amongst that, mental health nursing is in a bit of a strange space. So the strange space that we find ourselves in. So mental health nursing is the largest profession working in mental health globally. And we sort of like to think that that kind of meant something in terms of having a voice, having a bit of direction, having a bit of autonomy over where we sort of take the profession. But I actually wonder if it's the opposite, actually, that because we're the biggest profession in mental health, does it lead to us being seen as expendable? You know, I mean, well, we'll just kind of recruit more. I think that's probably similar for all fields of nursing, actually, is that we'll just sort of recruit more. And I think that has been a kind of the tack over the last number of years, is that we think much more about recruitment and less about retention. You know what I mean? So that's the analogy of kind of not pouring in more water into the bath without kind of actually putting the plug in to stop the water coming out the bottom. So we're the largest profession working in mental health, but our identity is still squashed within nursing and within the mental health space. So I think it's important to recognise those two spaces. Mental health nursing roles are context specific. So the work varies enormously, and like you think about the difference between a mental health nurse that might work maybe in a school setting, maybe in a community setting, maybe in an inpatient environment, and maybe in a forensic setting, or maybe in a prison. So these are different contexts, and actually the context itself will shape some of the kind of work. So that can make it difficult to sort of pin down an identity. And I'm going to pose these questions, and these have got question marks here because I hope that there is a bit of disagreement with them. And I ask these sort of questions to provoke particularly mental health nurses, but anyone else interested in mental health, to think about the role of mental health nurses. What do we actually do? So are we distinct and autonomous mental health nurses, or are we just psychiatrist assistants? Are we psychology light? You know what I mean? So we still work very closely with psychiatry. I think particularly in inpatient units, there's often a sort of culture of that being driven by psychiatry. Medication rounds are done, and often psychiatry can kind of lead a person's care in those environments, even though mental health nurses would spend the most time with people. I know obviously this varies kind of place to place, but I think we still do see that occurring. Are we psychology light? Certainly psychological therapies inform some of the work that is done by mental health nurses, but there's still this sense of like, is that ours? Is that really ours to do? What is ours? What do we do? Therapeutic prison officers, because we work with the Mental Health Act legislation, sometimes we are carrying around keys that can open doors, that can let people in or let people out. So there's that kind of attendant role, or agent of the state, if you like. You know what I mean? I'm kind of keeping this person in hospital for their own benefit or for the benefit of society, however you want to kind of look at it. Or are we counsellors with keys? I think I just sort of put that in because it was a bit of kind of rhyming and alliteration there. Medicalised social workers. I mean, certainly a lot of the issues that lead to mental health problems come from the social determinants of health. But are we in the middle of that kind of medical model bit, working with psychiatry and just delivering care that way? So these are social problems, but we're not social workers, but we'll kind of medicalize our sort of solutions to it. Again, I hope people are disagreeing with this vigorously, but I think it's important you actually disagree with this, because if you don't, these are the things that I think that we fall into. These are the tropes that people think that mental health nurses are. Or are we the other nurses as well? I think that there is often this stereotype of what a nurse is that is sort of set in the template of a kind of a general or adult nurse. And we might be seen as these other nurses that just think that they're different. So how are we seen? Yeah, okay. That's all I need to say there. So are we minions in the multidisciplinary team now? Phil Barker, a sort of legendary mental health nurse, a lot of kind of writing and advocacy for the profession, argued that developments in mental health nursing depended on the beneficence of psychiatry. Just this year as well, Timothy Wand, a great writer for mental health, argued we need to cancel psychiatric nursing and forge a new way forward. Certainly, he was there arguing that the psychiatric nursing puts us in that kind of psychiatric assistant kind of role without really an autonomy for ourselves. And certainly he'd be arguing that mental health nursing should be something distinct from psychiatry rather than in a kind of subservient role. Do we play the doctor-nurse game and do the dirty work of psychiatry? The doctor-nurse game is an interesting kind of thesis from, I think it's Stein is the original writer, from a great chapter here by Felton and Stacey in 2018, argues that actually when psychiatry and mental health nursing work together, mental health nursing can complain about doing the dirty work in terms of a psychiatrist can detain someone, but the mental health nurse tends to be the person that has to prevent them from leaving a ward, restrain them, administer kind of intramuscular medication, all those kind of absolutely horrible aspects of a job that should only be done if absolutely necessary. But I'm not sure it's always as kind of simple as that, to be honest. I think some of these instances could certainly be avoided. So there's that dirty work, but at the same time, psychiatry can feel isolated with the sort of ultimate decisions around risk. So a psychiatrist might say that they're the RMO, it's their kind of responsible medical officer, it's their name on the kind of Mental Health Act paperwork, and they feel that ultimate responsibility, and they can feel isolated with risk. And I think the thing is that each profession wouldn't necessarily trade for the others. So while mental health nurses might complain about that dirty work, they wouldn't necessarily trade and want that ultimate responsibility for risk, and vice versa. The psychiatrist wouldn't want to be doing that dirty work. I'm sure there's much more kind of complexity to that, and I think there have been instances where there are more nurse-led environments, and actually that can be much better for patient care. The rise of allied health professions and the disappearance of the mental health nurse psychotherapist. So, it's interesting. I've got good friends that are like occupational therapists and like other sort of professions. But it's been interesting that some of these other professions might now be doing things that we might have considered mental health nurses might have done maybe sort of 10, 15, 20 years ago. So why might an occupational therapist now be kind of leading, therapeutic groups, might be doing sort of talking therapies? Why has this happened while at the same time there's been a disappearance of the mental health nurse psychotherapist? So that nurse therapist thing used to be much more common than perhaps it is now, and we're kind of sort of fading from that. So we're in a really interesting space, and again, I don't want to, in the same way that I don't want to alienate any other kind of field of nursing, I don't want to alienate anyone else on the multidisciplinary team. These are just kind of observations around what has been happening for mental health nursing and why are we sort of being squashed into these odd spaces. A great paper by Mick McKeown, The Bullshitization of the Role of Mental Health Nursing. So he argues that uses the stuff from David Graeber, great writer, wrote the book Bullshit Jobs, to offer an analysis of what's happening in mental health nursing. And two things that he argues are that, like, the dirty work overshadowing that wholesome professional ideal is something that we really need to wrestle with. It's difficult to sell yourself as this wholesome profession that's about connecting with people and building relationships and facilitating recovery, however you kind of define that, or whatever sort of terms you want to use for people essentially feeling better, while there is still that coercive element to mental health nursing care. So it's difficult to reconcile that. But there's also that rise in paperwork and retreat into the office. And we know that, I think, everywhere there is, it seems like, a rise in recording things rather than actually sort of doing things. And is it becoming more about recording that a job has been done rather than actually doing a job? So is doing the notes at the end of a day more important than actually doing stuff during the day? It's about the bureaucracy rather than anything else. And again, that's something important to think about. Are we perhaps viewed by society as the worker bees or minions of the mental health care system? Do we exist everywhere but belong nowhere? I mean, where's that bit that is mental health nursing, that belongs to kind of mental health nursing? Where's that bit that we can say, this is ours, this is the bit that we absolutely do, other professions don't do this, we do this, this is ours? Not sure we have that. And we have less time in education, but are closer to service user than any other profession and operate in perhaps the most complex space in mental health. I still think that 3 years is really pretty quick to sort of register as a mental health nurse. I think it's an incredibly kind of complex job. So there's 3 years and then you're out there doing it. And I guess if you compare that to somebody studying psychiatry and, you know what I mean, studying medicine, going through that route, you may be talking about 7, 8, 9 years. So it's quite a quick education that we have. But I think the job that mental health nurses end up doing is actually more complex. And I'm gonna die on this hill, right? I'm gonna die on this hill. Okay, let me walk up to the top of this hill and I'll die on it. I think the job of a mental health nurse, particularly in inpatient settings, probably more than any other, is more relationally complex than the role of, I guess, our sort of peers in mental health care, psychiatry and psychology. And the reason that I say that is that psychiatry and psychology tend to have more time-limited, almost appointment-based kind of contacts with people, and not belittling the complexity of it in any way. I'm just saying that mental health nurses in this space have a more complex role. And I've thought a lot about this, and I've thought, like, what are the things that mental health nursing does that other professions don't do? You know what I mean? You've got things that you could say, well, is it medication? Well, psychiatry kind of prescribe medication. Mental health nurses administer it. Sometimes you get nurse prescribers, but it's not ours. It doesn't really belong to us. You've got sort of talking therapies, psychological therapies. Well, you've got sort of psychology that does that. You've got counselling, sort of psychotherapy, sometimes as independent professions. You've got the rise of the allied health professions sort of doing these things now as well. So that's really not ours. And I thought a lot about this, and the two things that I came up with that I think are hopefully going to convince you of my position on this, so I don't die on the hill, I'm just standing on it. The two things that are unique about mental health nursing are that we're closer than any other profession, in that we will work with people in these spaces and be present 24/7. There will be nurses around in particularly inpatient environments, and we're actually the most available and usually the most accessible to people in mental health care. I think once you're in mental health care, that would be true. I think if people are arguing about accessing care, there might be quibbles with that, and I would certainly allow that. But I would think we're probably closer or more accessible than other professions. But the other one was physical restraint. Other professions don't do that. Psychiatrists don't get involved in physical restraint in the same way. Psychologists don't do that. Counsellors don't do that. So mental health nurses have that horrible space of needing to connect with people, build relationships, consider risk, all that stuff, while being incredibly close to people and having the power to physically restrain them. So that's where I think that relational stuff needs to be much more robust than relationships that are needed in psychiatry, psychology, and certainly relationships that might be needed in other fields of nursing, probably bar learning disabilities nursing, where I think there's a lot of kind of similar complexities with human rights and connections and stuff like that. So anyway, that's something for you to think about. So are we also the ghosts of nursing? So I've talked about how we might be kind of squashed within the mental health space, but how are we squashed in nursing as well? So, and I've written in the paper as well, so it seems that the development of mental health nursing doesn't just depend on the beneficence of psychiatry, but also depends on the beneficence of dominant and orthodox paradigms of nursing. So what it means to be a nurse. There's almost like we need to be allowed to be mental health nursing by what it means to be a nurse. This ideology of what it means to be a nurse around mental health nursing can actually impede the progression of the profession. I think for a long time it's been argued that nursing narratives in general can exclude mental health nursing at times. Happel arguing histories of the nursing profession tend to focus on the care of people experiencing physical illness or injury. Mental health nursing is either totally absent from or receives only superficial mention within these historical texts. And mental health nursing has a very unique history in terms of nursing. It's not identical. It's very, very different. And certainly going back to, I think people should Google this rather than rely on my memory, but the character Ethel Fenwick, who strongly opposed mental nurses as they were known at the time, I think in the 1920s, being allowed onto the nursing register. There was a resistance to mental nurses being part of the nursing profession. So there's been a conflict between mental health nursing and wider ideologies of nursing for a number of years. I mean, certainly at least 100 years. So it's important to keep that kind of history in mind. Pat Cullen, before she'd kind of sort of left her position at the RCN, had said, let's give nursing its fresh start and a new place in healthcare. And that was kind of talking about all this discussion around a sort of a different pay spine for nurses, recognizing the complexity of the jobs that they do being valued. Definitely a conversation that needs to be had. But I think actually mental health nursing needs a fresh start in nursing as well. I don't just think nursing needs a fresh start in healthcare. I think mental health nursing needs a fresh start in nursing. And I would strongly argue that. And another thing that's sort of keeping us ghosts is that we're currently in the UK being given a kind of generic education for a unique job. Now, our colleagues and peers in Australia have argued that mental health being subsumed into a comprehensive Australian nurse training means that graduates are not job ready. So in Australia, people will do a comprehensive nursing program, which is supposed to get you prepared for anything in nursing. But what they argue is that it sort of favours physical health and probably that adult nursing kind of mentality, and people are not job ready for actually working in mental health environments. And I think the UK perspective, which we've argued before, sees a startling absurdity that the physical health of people with mental health problems is given more attention than the mental health of people with mental health problems. So there's something, again, coming back to that recognition that people have a reduced life expectancy when they have mental health problems has kind of led to, I think, a misunderstanding that the best way to address that is to increase the physical health capabilities of all nurses. And I think what's happened with that is that because a course is a time limited vehicle, if you're adding in more physical health content, something's got to give. And actually what gives is the mental health content. So are we arguing that the physical health of people with mental health problems is more important than the mental health? And it's about kind of what you sort of prioritize. I think if you're calling somebody a mental health nurse, maybe that should be what they focus on in their education. And that's not to say at all that they neglect physical health in any way. And I'll certainly kind of come back to that. Anything else? Yeah, so I mean, the comprehensive stuff in Australia, I mean, sort of prominent professors over there, thinking of kind of Richard Lakeman, John Hurley have done lots of work on this, and it's been described as a 30-year failed experiment for mental health nursing. It's not been described as a good thing, but there's obviously still lots of kind of controversy and different opinions around that, in the same way that we're having in the UK. Yeah, okay, that's enough there. So this is when I've talked a lot about the future nurse standards before, and again, some of this is I've put in the recent paper, the Memoir of a Ghost. Now, the future nurse standards, I would argue, we can understand what has happened here with reference to the emperor's new clothes kind of metaphor analogy. So this story it's Hans Christian Andersen. So if I can sort of recount the story very quickly. So two tailors go to an emperor and they offer him these new clothes. Say, got these new threads. That's what the kids say, isn't it? We've got these new threads. You know what I mean? You'll look amazing in them. But they say only the worthy people can see them. You know what I mean? They're like, I know that, you know what I mean? They're basically offering him nothing and saying that only the worthy people can see them. So the emperor doesn't want to sort of pretend that he's not worthy. So he's like, gets these invisible clothes, well, gets no clothes, but gets offered this and says, oh yeah, they're brilliant. And then brings in kind of other people within the sort of kingdom. You know what I mean? Imagine his closest advisors saying, oh, these two tailors have made me these amazing kind of clothes. What do you think of them? You know, I mean, only the worthy can see them, by the way. And obviously no one wants to appear unworthy. So they're like, gorgeous, they're beautiful, brilliant, like amazing. They look amazing. And gradually this kind of continues and goes on and goes on and on. These great clothes, only the worthy can see them, because as human beings, we've got these fragile egos and nobody wants to be the odd one out. Nobody wants to feel like they're unworthy or that they just don't get it or something like that. So everyone's kind of going along with it until eventually a child shouts in the street, he's naked, by the way. And that sort of breaks the seal. You know, I mean, once it's said out loud, there's kind of an outpouring of, oh yeah, okay, yeah, he is actually naked. So people are actually, after a point, they're pointing out the obvious. What was obvious all along, they're pointing out. Now, what I think here was the new clothes was the new future nurse education standards. So this is where the NMC introduced in 2018 the same generic standards for all fields. Now, the NMC would argue that it's holistic and not generic, but what generic means is pertaining to all sort of aspects of a class. And because it pertains to all nurses, they are generic nursing standards. That's like by definition, that is what they are. So brought these in. So I'm arguing that these are the new clothes. Now, I think people are reluctant to question these standards, but some do. And there was pushback at the time that these were being introduced. There's a reluctance to question because truth by authority or truth by consensus is a really powerful influence for human beings. It's really difficult to be that kind of odd one out. And I think there was a logical fallacy in thinking, if the NMC have decided this, it must be true and it must be good. And I think that's the kind of, we end up with a lot of that in society, in life, is that there's just this belief in authority, and it's comforting, isn't it? It's comforting to believe in authority. It'd be so comfortable to believe that the government has your best interests at heart. They exactly know what they're doing. They're completely on the ball. But sometimes a stupid decision is a stupid decision, and it needs to be kind of called out as such. So I think it's important that we're all very, very careful. We're not just falling into that. This is true, not because it makes sense, but because this authority has said it. And I think that's what happened. I think there is a lot of kind of subservience and sort of blind faith in the Nurse and Midwifery Council that I don't think is necessarily a good thing. I think we should always be questioning power. And what I've argued in the paper as well is that I think that the way things are, the Nurse and Midwifery Council is like a government without an opposition. There's not really a sense of being accountable to the rest of nursing, sort of does consultation on its own terms and doesn't necessarily have that kind of accountability to actually the people it should be regulating and actually should be serving as well. So I'm going off in tangent and losing my thread of thought. So people are reluctant to question because of that truth by authority, but people do, and I certainly wasn't the only one to raise concerns, but maybe kind of did it in most dramatic fashion with a big email to colleagues at Mental Health Nurse Academics UK. It was just a bit of a sort of banging my head against the wall, feeling a bit exasperated about the situation. Mental health content has sort of disappeared out of my course, and this sort of led to lots of people kind of coming together. So you could argue that that's maybe I'm the child sort of pointing out he's naked. You know, I mean, there's actually, where's the mental health in this? And it's led to a disappearance of mental health in this. And once it's said out loud, more people feel comfortable kind of sort of saying this out loud as well, and the voice gets louder. And this led to the Mental Health Deserves Better movement, and an open letter that was written to the Nurse and Midwifery Council and Chief Nursing Officers and Council of Deans in 2023. And I'll put a link to that in the description as well. But the Emperor continues to proudly wear his clothes, as happens in the original story. The NMC and the CNOs have continued to defend the standards. In a reply to that letter, they said it was sort of too early to tell, and there wasn't really a sense of acknowledging the concerns of Mental Health Deserves Better and all the people that signed that letter. So, anything else I need to say there? No. Okay. So what's in there and what's not in there? So thinking about what's actually the detail of the future nurse standards. Now, certainly, I would argue that like everyone should probably go and have a look at it if you haven't, because I think there's some stuff in there that you can say, yeah, okay, that's fine, that makes sense. And there's some stuff in there that you're like, I'm not really understanding what you mean there, or I don't understand how that is contextualized to each field. And I'll kind of talk through some of the concerns about it here. So what's in there? And remember that these are for all fields of practice. So this is for mental health nurses, adult nurses, children and young people's nurses, and learning disabilities nurses. So the argument is that all people should be able to do these things. So what's in there? Manage and monitor blood component transfusions. Yet to find mental health nurses that are doing this. And again, it kind of feels like, why are we learning this if we're not going to do this, especially when courses are short? And why would we waste any time when we've got important stuff to discuss and to try and educate people as best we can? Insert, manage, and remove catheters for all genders might be more applicable, but again, is it the day-to-day of every mental health nurse? We can sort of debate that. And then we've got annexes at the end. So communication and relationship management skills. The first thing to say there is that I don't like the language of relationship management. I mean, I think that if you're going into any relationship thinking that it's something to be managed rather than maybe built, maintained, developed, something like that, I would have maybe kind of preferred. If you're going into something thinking it's going to be managed, maybe that sort of sets the wrong tone for a kind of reciprocal relationship. So communication and relationship management skills. And in here, you've got a sort of list of things that all nurses should have some skill in. And again, motivational interviewing, solutions-focused therapies, cognitive behavioral therapy techniques, talking therapies. Again, I'm not clear how much does an adult nurse need to know about that. You know what I mean? Children, young people's nurses, how much do they need to know about that in terms of the sort of day-to-day jobs that people are going to do? I'm not sure. Another thing to sort of pick up here, and I pick on this every time because it bugs me, because it sort of looks like somebody hasn't really thought about what they're doing when they've put this together, because you've got motivational interviewing, solutions-focused therapies, cognitive behavioral therapy techniques, talking therapies. So solutions-focused therapies, cognitive behavioral therapy techniques, talking therapies. It's like almost like, so imagine you go into a kind of cafe and you see a menu and it says that you can get a beef sandwich or a cheese sandwich or an egg sandwich or a sandwich. So you're like, what's that sandwich mean? Does that mean like a random sandwich or all sandwiches? You get a bit of like, what does it mean to specify individual therapies and then say talking therapies? Like all of them, I think like some of the way that this is put together is kind of very sort of confusing and difficult to understand. Then Annex B, recognise, respond to challenging behaviour, providing appropriate safe holding and restraint. Again, I think with the Mental Health Act and, you know, I mean, sometimes people being detained, mental health nurses and learning disabilities nurses, absolutely. I think that would be important. But adult nurses and children and young people's nurses, I'm really not sure why that would be as kind of relevant. You know what I mean? Certainly not the restraint bit. And then Annex B, undertake venipuncture and cannulation blood sampling, interpreting normal and common abnormal blood profiles and venous blood gases. And again, I'm not sure that this is something that is commonly done in mental health settings. I'm struggling to see when a course is limited, why are we doing all these things? So those are some of the things that are in there, but I encourage people to look at it, make your own mind up in terms of what's relevant and what's not. But what's not in there? And the first thing to say is there is absolutely no contextualization. There's no guidance around the degree of contextualization or depth for any proficiency for any field. Now, it does say in the standards that these should be contextualized to field, but it offers no guidance as to how to do that. So that is then sort of left to universities to kind of figure out. So how much does an adult nurse need to know about motivational interviewing? Well, the university will just decide. How much does a mental health nurse need to know about blood component transfusions? Well, the university will just decide. So there's no kind of NMC saying that this is what we would expect from each individual field. So they've kind of almost taken a step back from what it means to be any individual field nurse. And they've just got these sort of generic things that I think are so broad and open to interpretation that it can become unhelpful. Also, things that are not in there The Mental Health Act doesn't appear. Human rights, the words don't appear. Power and power dynamics doesn't appear. Trauma-informed care, the words don't appear. Diagnostic overshadowing, actually probably one of the reasons it's argued that people might have poorer physical health when they've got mental health problems, because everything's viewed through the mental health lens rather than physical health. That's not in there. The contested validity and impact of psychiatric diagnosis, that's not in there as well. Now, this is not to say that these things won't appear in a student's education. What it is to say is that they don't have to, because they're not mandated in any way. They're not sort of put in there as things that need to be addressed. Now, you could argue, and I'm convinced that the NMC would argue, that there are broad standards that capture these things. So, for example, one of the standards is about a student should know all relevant legislation pertaining to their field, something like that. So you could argue that, okay, all relevant legislation, Mental Health Act, that kind of goes in there. But I think understanding the Mental Health Act is more important than just sort of leaving that to the chance or interpretation of a university. I think that actually these things need to be kind of emphasized. If you're going to have standards, and I think there's some good papers by my good friend Freya Collier Sewell. I hope I've said that right, Freya. They actually sort of talk about how standards might actually get in the way of producing kind of critical thinking nurses. And we should definitely sort of think about them. But if you're going to have standards, at least put in the things that would be of most benefit or use to mental health nurses. Okay. Yeah, okay, that'll do from that. So the emperor has no clothes, is what I'm arguing. With the future nurse standards, the emperor has no clothes, and mental health nursing is naked. So there's no specific education standards for mental health nurse education. You've got these broad standards that pertain to all fields, and the contextualization is down to the university interpreting that. Also, there's no hour requirement for field-specific placements. So there's no minimum requirement of hours mandated by the Nursing and Midwifery Council that says that students need to spend 2/3 of their training or this however many hours. And we've got 2,300 hours still in placement in the United Kingdom. There's no set kind of 2,000 hours needs to be in mental health settings. Again, that doesn't mean that people aren't spending the majority of their time in mental health placements. It means that that's not really sort of protected or mandated. And it's a bit of a kind of hole. And I think I've talked about a sort of sieve of circumstances that can lead to mental health nursing just sort of falling out the bottom of nursing. And there's no weighting requirement for field-specific teaching in university as well. So there's no mandate saying in contextualizing these standards, 2/3 of a mental health nurse students program needs to be field-specific. So out of 8 modules, you know what I mean, I should have picked 6 because I could do the maths better. Out of 6 modules, 4 needs to be field-specific. There's nothing saying that. So again, these things come down to the interpretation of universities, and actually I would say sometimes down to placement capacity. And we do know that people from studying mental health nursing will experience adult nursing environments. We know that adult nurses will sometimes experience mental health environments. And I don't have a problem with that, because I think that actually exposure to different environments can be good in terms of developing your skill set. But again, I'm a little worried that that's sort of just being left to the interpretation of universities that might use issues such as placement capacity to just put people wherever. So again, it's something to think about, and I think these are some of the problems that continue to frustrate mental health nursing. The same practice assessment document for all fields of nursing. So when students are out on placement, they have the same practice assessment document. So a mental health nursing student in an adult acute inpatient unit that might be dealing with people that are experiencing kind of psychosis, depression, where, there's complexities around human rights, they will still have to sign off blood transfusions. They will still have to sign off catheters. So there's a sense of a mismatch between this practice assessment document that's asking everyone to do everything, no matter any placement, and the jobs that people would do. And it would also have similar kind of concerns around how is an adult nurse going to sign off CBT in an emergency department, or how is this happening? It doesn't make sense to me. Questionable quality assurance processes. So there's three things that happen when that go into a student's education. So the Nursing Midwifery Council, NMC, they develop these future nurse standards. Second part is that these are then interpreted by universities. And the third part is that then the courses offered by universities are approved by the NMC. So the NMC are part of that process. They actually kind of outsource that and somebody does that on their behalf. But essentially, that is their responsibility. They are responsible for assuring those courses. Now, we know from conversations through Mental Health Nurse Academics UK and Mental Health Nurses, Mental Health Deserves Better, that poor courses, poor in terms of weak mental health content, have still met the standards and they've been approved. And I think that means that the quality assurance processes must be something wrong with them if poor courses are getting through and being approved. One of the worrying things that we sort of learned over the last couple of years as well is that there was actually no need for the quality assurance visitor to be a mental health nurse, just a registered nurse. So I could be a mental health nurse and I could approve a course about adult nursing because I'm a registered nurse. That's the sort of the bar. You need to be a registered nurse. But I don't feel like I know enough about the complexities within adult nursing, children, young people's nursing, learning disabilities nursing to do that justice. I respect members of that field to know about their field. So I think it's worrying that mental health nurse courses, or the courses that mental health nurse students will experience, can be approved by somebody that doesn't have any experience or any knowledge about that field. And what we've heard within the Mental Health Deserves Better group is that actually people are coming along to quality assurance visits and they're not asking about mental health. They're not asking about it because they don't even know what questions to ask. That's a huge glaring problem inside the entire system. And a massive problem with genericism is that people don't know what they don't know. And I don't think it's necessarily a deliberate neglect of mental health nursing a lot of the time. Is that just the way things are set up? People don't know what questions to ask, and mental health, again, falls through that sieve of circumstances. So thus, there is no promotion of mental health nursing identity or protection for mental health nursing identity within that. And what I argue is that then what you get is weak sauce. And certainly what I experienced at my previous employer was a course that kind of almost sort of felt like it was kind of smuggled in the middle of the night and kind of given to us, and this is your course. Kind of looking at it going, that's not my mental health nursing. And I think that it is due to these sort of generic standards that are so broad that they can be interpreted in a variety of ways, and they don't protect the identity of mental health nursing in any way. In fact, in the standards, it doesn't say anything at all about what it means to be a mental health nurse. The regulator doesn't offer anything in terms of the philosophy of mental health nursing. And I think that's a huge problem. And I think we're sort of let down by the NMC in that regard. So I'm looking at this course and thinking that like people aren't getting a sort of dedicated module on therapeutic relationships until their third and final year. It's shared learning in the first 2 years. students are also out on placements in different fields, so they're not necessarily getting placements in mental health. They're not necessarily getting mental health content, although the argument is that the shared learning covers everything. What the experience of mental health nursing students and academics is that the mental health tends to be tokenistic or marginalized or sort of pushed out to the side. And so I've kind of been left thinking, I've been thinking this for a while. I think it's important to sort of say this out loud. I've often wondered if I picked the wrong profession. And I guess it goes back to that Emperor's New Clothes bit, isn't it? It's like, am I just unworthy? Do I not see this? Is it just me that doesn't get it? Maybe I should have done something different with my life. Maybe I should have been a psychologist. Maybe I should have. Maybe it's me that's the problem, that I don't understand the genius of the NMC and these future nurse standards. But I just don't buy it. I just don't buy it. I think mental health nursing has unique complexities that have not been recognised or promoted. Yeah, I think I'm right. Basically, I've thought enough about it that I'm looking for that. I'm genuinely looking for that moment where I'm really convinced that this is the right way to go, because it would save me a lot of time in terms of writing papers and talking to myself in a room. But I am just not convinced. I have to be honest. I'm just not convinced. And what you end up is teaching on a course that you don't believe in. And certainly I had the experience of kind of student nurses, you know what I mean, at like the end of their second year, meeting me in the coffee queue at the university and saying, when we're getting taught about the mental health stuff. It was difficult to defend that. Like, there's something wrong if that is a student's experience. Give you a moment to take that in. This is the meme that keeps on giving. It's just great, and it's such a versatile kind of setup, this meme. But like, if you look at mental health nursing there, that was kind of my face when all this sort of occurred. The Nursing Midwifery Council looking over at the future nurse standards with this fantasy of a genetic super nurse that's good at everything, as well as an expert in their field. Because what they say is that these are holistic standards, and they say that we want nurses to be doing this, but also have advanced skills for their field. So, and what I've argued before in another paper and speech was that they're wanting their cake and eat it. They want both. They want this super nurse that is good at everything, as well as really good at something specific. And I just don't believe that you can do that. I think that humans are very imperfect, fallible creatures that can maybe do one thing really well and aren't necessarily great at doing everything. I certainly put myself in that category of, I think I'm decent at some things. I am terrible at a lot more. And I think wherever you focus your efforts, you become better at doing that thing. And do you want that sort of jack of all trades, master of none? Or do you want somebody that has a bit of specialist expertise that can actually provide improved care to the population? And again, what I was saying before, it's not like mental health is getting less complex. It's like the world seems to be becoming more complex in terms of how we understand and address mental health. And yeah, so of course, I think that genetic super nurse that is good at everything as well as an expert in their field, I also find that attractive. I think that, whoa, that would be great. I just don't think it's possible. I think that it comes down to pragmatism. I just don't think that can be done. Again, I'm happy to be proved wrong, but as yet, I've not been proved wrong, because what I've heard is people feeling underprepared for going out there. One example off the top of my head, you know what I mean, kind of mental health nursing student teaching himself about the Mental Health Act after qualifying, because now he's doing the job and he needs to understand it. That's not really good enough. This second meme here as well. So do we wonder if this is in the mix as well? So mental health nursing, again, looking at the university, and the university thinking, future nurse standards, genetic standards. Now we could teach nurses all the same thing. And maybe we'll save a bit of money by having less modules, because we can just squash all nurses together as far as we can, and maybe we'll need less staff to teach. Now that's very, very, very cynical, but some universities are run very much like businesses. I've described it before as that sort of monetized kind of nurse factory that people are just sort of churned out, and it feels like this big kind of conveyor belt. And there is a lot of discussion about how you can do things quicker and cheaper in the same way that you would have in the National Health Service. I think universities are also kind of struggling with resource in the same way. But I wonder if this is actually two things that go on here, that it's actually a combination of that factory mentality and also that sort of blind faith, that truth by authority allegiance to the NMC, that the NMC say it, so it must be true. And I think there's a lot of people in nursing that have that mentality, which I just don't think is helpful, and I don't think it shows any kind of degree of critical thinking to just sort of think the NMC say it, so it must be true. So you get this situation where, because it's the future nurse standards, all nurses need to learn the same thing. There can sometimes be a mentality of like, well, anyone can teach anything then, because we're all nurses, aren't we? A nurse is a nurse. So we can get adult nurses in teaching cognitive behavioral therapy when they've never done it before. I might be in sort of teaching about catheters when the last time I did one was 2008, and even that was kind of supervised, and it was the only time I ever did it. And that doesn't feel to me like the best way to educate students. So there's this sort of mentality of same standards, same learning. There you go. And to be contextualized is all that needs to happen for something to be contextualized is for a university to say, yeah, we've contextualized that. And that's done to varying degrees. I think some of my former colleagues, what they would say actually about this, saving money by having less modules and needing less staff to teach, that actually say that no, that hasn't happened. It kind of continues to occur, just more inefficiently. So something to think about. Now, some of the dirty laundry of nurse education, I guess that like a lot of this is written about in the memoir of a ghost paper. But this is some of the kind of behind the scenes to what actually happens within a university setting. So within some universities, there are messy politics that vary very much depending on the institution. So there's no guarantee that mental health nursing teams have autonomy over their courses. So I think it's important to recognize that, you know what I mean, that like mental health nurses working in universities don't necessarily have the power to shape and influence the courses that they would like. Sometimes they are feel like sort of minions within that sort of system and have very, very limited power. Monetized nurse factories, I think I've described that just a minute ago, where university reputation is more important than actual quality. Now, this sort of gets in the way of actually sort of speaking out about these things. And that's certainly some of the stuff that I've detailed in more depth within the paper. So some specific experiences that I had, was it like nursing being seen as a single course. So with a single course lead for all fields, and any shared learning is best suited to adult nursing. Now, I think that actually in a lot of universities, because adult nursing dominates the nursing profession just through sheer numbers, what you often get is people in senior positions in universities that might be all kind of adult nurses. And I think this sort of happens often by accident. I don't necessarily think it's some grand evil scheme or anything like that, but I think you get a situation where people don't know what they don't know. And they don't sort of see those bits that are missing for mental health nursing. They don't see the unique nature of mental health nursing in the same way that mental health nurses might. And then when a course is shaped, it's shaped to suit the kind of the biggest number, just through sort of default rather than any kind of grand plan. Speaking out against the direction for mental health nurse education was met with me getting a disciplinary for harming the university reputation, and a polite cease and desist about kind of writing academic papers on the subject. Again, that's sort of written about in more depth in the paper. And for bonus content for this version of the presentation, I'll show you the original tweets, the April Fool's jokes that got me in trouble at the end of this presentation as well. And I hope you'll join me in a belated chuckle, because certainly the NMC and the university didn't find it funny. A student leaving the course to lack of mental health content, but then the attrition being recorded as poor course choice. So this was actually recorded as, so the students left, why are they leaving? Let's record this data. It was recorded as poor course choice, as if the student had chosen the wrong course, not that actually the course didn't have enough mental health content to satisfy the students' needs. So this kind of problem is silenced by the way that universities might actually record this as well. There was an instance of research exploring student experiences into future nurse standards blocked from going to students. So again, university being worried about reputation, even though there was the promise that this particular piece of research, which I had nothing to do with, it was coming from a different university, there was assurance that universities would not be named through any kind of publication. The dean and the sort of middle management chose that this would not be offered to students. So students didn't even get the opportunity to express their own opinions through research. So essentially, and I argue that that kind of controls the narrative around this, and I think that's hugely problematic. I mean, I think that's like, it feels corrupt. I can't think of a better word than it feels corrupt to kind of get in the way of building that sort of evidence base. And mental health nurse academics experiencing moral injury and leaving. Now, we know that actually when the future nurse standards came in, a lot of people took maybe retirement that had been looking to do that. Mental health nurses that said, I'm not going to be doing what I love anymore, so it's now my time to go. A lot of people have left to sort of go back to clinical practice. And I myself sort of left that university and now work at a university that only teaches mental health nursing, a very, very unique position where even though there is the future nurse standards that are still met, at least it can be contextualized without that sense of trying to meet the needs of every field at the same time. Yeah, and the meme there, don't always air my dirty laundry in public, but when I do, I don't do it on Facebook. And for anyone that's working in a university setting, certainly be very careful about what you put on social media, because apparently that doesn't count as academic freedom in the same way. Although I think you could certainly argue that a lot of these spaces are used for the exchange of academic ideas. So what's this mean for clinical practice? So essentially, students are in a lottery of field-specific education. Some universities have got robust mental health nursing content. Some have weak and generic offerings, you know what I mean? So that kind of weak sauce. And there's a massive amount of interpretation that has kind of went on in there. So there's no consistency to the knowledge and skills of newly graduated mental health nurses, but they all achieve the same registration. So you're actually in a position where the quality of a mental health nursing registration probably depends on where they actually got that registration, where it depends on where they sort of did that education. And I think that's a problem for the entire United Kingdom, because obviously somebody could, you know, I mean, study anywhere in the UK and work anywhere else in the UK. So that's really, really difficult if there is that massive inconsistency. So varying degrees of upskilling might be required when people qualify and go into mental health nursing environments. You might notice people are maybe not as knowledgeable and skillful as you might have expected or you might have thought. And I guess my sort of message to folk in clinical practice here is that try and offer a bit of kind of kindness and forgiveness to students that might not know as much as they could have, because it might not be their fault. It might not actually be about their lack of willingness or I mean, that they've just not worked hard in the university setting. It might be that actually they've just not had enough dedicated time to understand mental health. This paper from Australia argued that the use of restrictive practice might be argued to be linked to a lack of education. So where there is maybe a lack of advanced communication skills, people are quicker to resort to physical restraint because they don't know how to de-escalate. They don't know how to have a conversation, and they will sort of default to that physical intervention that kind of they think will resolve the situation, because they don't feel able to kind of do that in any other way. So I think that's a huge, huge problem, when actually we should be trying to reduce coercion rather than kind of put people out there that are unprepared and actually much more likely to use physical restraint. And I think that when we don't know, imagine mental health nurses not knowing enough about mental health, then you become a ghost in the multidisciplinary team. And what we've argued before is that with limited specialist training, the nurse may become less influential and useful in the multidisciplinary arena, carrying with them a deficiency of specialism, which was sacrificed for the illusion of holism. So I think that actually this does a disservice to nursing as a whole, because people are going out into sort of specialist environments. Like, nobody goes into a generic nursing job. They go into a post as a registered nurse mental health, registered nurse adult, registered nurse learning disabilities. So they go into these specific environments. So having a generic underpinning for going into a specific job means that you might be missing a lot of that sort of specialist education that would have elevated your status and your value to the multidisciplinary team. And if somebody, imagine an MDT sort of situation, and I mean, you've got the complexity of mental health. It is never simple in terms of anything about kind of what might have caused the issues and how to resolve the issues. It's always a minefield understanding that stuff. And you've got a student whose head is bursting with just hadn't studied blood transfusions and catheters and stuff like that they're never going to use in that setting. And they've maybe missed out on a depth of understanding that could have made them more useful in that environment. So what you do actually is then make mental health nurses less useful in the multidisciplinary team. And that's going to further push the profession just into non-existence. I mean, we're just going to absolutely sort of disappear. I'm aware this is getting quite long, but I guess the value of recording this means that you can pause and you can go for a pee, or you can have a break or a coffee whenever you want. Yeah. And it means that actually whenever I've done this before, when I did it in Manchester, I cut it short. So this is going to end up probably being at least sort of half an hour longer than what it was. Mental health nurse well-being. So we know that there are concerns about, I think, the well-being of all nurses. We know that the sort of suicide rates for nurses, particularly women nurses, has been a huge issue, and something that we need to pay attention to. But these are some things I actually took from my own PhD study that should be, again, available online over the next kind of couple of months, and I'll sort of put that in the description when it's available. So well-being for mental health nurses is influenced by many factors. I mean, it's a complex role in a complex world. But some of the experiences that I got from mental health nurses that I interviewed, were like, the caseload's too big for me. It's fearsome. So this sense of just having to try and look after so many people. And I think that the further you're stretched, I mean, the less effective you can be, and it becomes really, really difficult. Managing and holding high-risk cases is a frightening thing. So it's incredibly anxiety-provoking to work with people that might die by suicide, or might kind of self-harm. It might sort of commit violent acts to themselves or to others. And to feel like you're sort of holding that is an incredibly complex thing. Again, one of the reasons that I think that we need to recognise the specialist nature of working in mental health services and why mental health nurses need this. Think that we will live in a blame culture and we are sitting ducks. So that sort of sense that there will be blame put on mental health nurses when, if anything goes wrong, they'll be blamed by patients, they'll be blamed by colleagues, they'll be blamed by families, they'll be blamed by the regulator, they'll be blamed by the press, by the media, all that kind of stuff. And that contributes into sort of decision making, isn't it? If you're so anxious about something bad happening or getting into trouble or getting blamed when something goes wrong, it will impact on your decision making. Maybe you become more risk averse when positive risk taking or tolerating risk might be a better kind of a better tactic. Mental health nurse here feeling the patient is too unstable, so let's give them to the nurses. So a mental health nurse feeling that actually you never got to say that. Like, so one of my kind of bugbears actually, it came out in my study as well, was when people were told that they were too unstable for therapy. So people couldn't meet criteria to get psychological therapy because they were unstable. They were in crisis. They were going to the emergency department, that kind of thing. But this mental health nurse made a good point that sort of nobody ever says that they're too unstable to go to mental health nurses. And actually what often happens is if somebody is deemed too unstable for therapy, which I don't really think is a too unstable for, you know what I mean, like go away and get better and then we'll help you. I never really understand that kind of mentality. But nobody else ever says that a person is too unstable for mental health nurses. We work with people actually at their worst, you know what I mean, crisis points and stuff like that. And nurses can feel like they're sort of left in the firing line of probably the most kind of complex patients. Again, coming back to the point that we have the sort of quickest education and then we're out there with probably some of the most complexity ever. Working in these really difficult environments, halfway through a conversation and the alarm goes. So your attention is pulled and your adrenaline is going up and down all the time. And in that environment, you're expected to try and connect with people and provide sort of therapeutic care. And then you cry in the toilet and then you go back to work, recognizing the incredible stress and sometimes psychological trauma that mental health nurses have experienced doing the job. But there is this sort of culture of get on with it. Now, I'm not saying that you give people a good education, it fixes this, because I don't think it will. I think it's a wicked problem, isn't it? It's kind of multifaceted. Education won't fix this, but poor education, poor preparation for this complex role will make it worse. Again, that's another hill that I'll die on there. If you don't prepare people well for the job that they're going to do, they will feel worse about it. They will experience a lot of anxiety. It's my final one of these memes, but again, I wonder if it's in the mix. And again, it's for probably people that are watching this to sort of tell me, or, you know what I mean, have a think for themselves. But is an influence in geneticism coming from health boards as well? You know what I mean? So mental health nursing, they are looking at health boards and employers and thinking that, oh, look at that. That looks great. A genetically trained nursing workforce where anyone can work everywhere. Okay, this person's a kind of mental health nurse. This person's a children, young people nurse, but they both did the Future Nurse Standards. They should both know everything. So maybe I can pick one up and put it over here because we're short over here. Again, that might be cynical. I don't know, but I wonder if this has had an influence. And certainly some of the kind of policy documents over the last few years have talked about the desirability of that flexible workforce. And I think that we need to be careful with that, because does flexible mean that people are necessarily going to be good at what they're going to be doing? They might be flexible, might be able to put someone there, but are they going to be good at it? And that sort of brings me on to the next point, that actually this replacement of nurses is actually kind of already happening. So the Royal College of Nursing 2023 approached by members claiming inpatient mental health services were substituting learning disability and mental health nurses with children and adult nurses. People were asked and claimed there had been shifts in their wards with no mental health or learning disabilities nurses. So a third of 608 mental health nurses, 110. 40% said this occurs sometimes, 30% said it happens often. Now, it's potentially unlawful given mental health and learning disabilities legislative authority to use nurses holding power. So the ability to restrict a person's human rights, for example, in an inpatient unit, stop a person from leaving for 2 hours until a person is reviewed by a kind of a psychiatrist or doctor. So you're putting people in positions where they don't have that power. So that's actually, I would argue, it's potentially unlawful, and also it's not necessarily fair on an adult or children and young people's nurse who don't have the authority or ability or education to kind of do that. So we'd argue that mental health nurses should have a specialist skill set, because we do have unique legislative power, because we work with the Mental Health Act, because we have nurses holding power. That feels like a very, very unique and distinct thing that needs to be addressed in the future nurse standards, or in the kind of education standards or underpinning for mental health nurses. We can't sort of leave that to chance that a university will decide that that's important. That needs to be emphasized. Now, the reason I've got the kind of the two sort of football pictures there. So I'm a Aberdeen Football Club fan, long suffering, because we've not sort of done anything really that meaningful since Alex Ferguson left to join Manchester United, and you might know that was quite a long time ago now. These two pictures here are from the cup final, the Scottish Cup final in May the 27th, year 2000, where Jim Leighton, the Aberdeen goalkeeper, went off injured in the third minute of the cup final. Now, the manager didn't have another goalkeeper on the bench. So what happened was they took another outfield player on, and Robbie Winters, who's a striker, went in goals. Okay. Now, the reason I'm using this analogy is that these are both footballers, right? One is a goalkeeper, one is a striker. In the same way that mental health nurses, adult nurses, children, young people's nurses, they're all nurses. But there's something different about the fields of nursing, and there's something different about being a goalkeeper to being a striker. And what do you think happens when you put a striker in goals? Aberdeen lost 4-0. Now, anybody, and Robbie Winters did his best. I think where this analogy falls down is that actually Aberdeen were used to getting sort of pumped that entire season, and it wasn't actually unlikely that they were going to get beat 4-0 anyway. But the point I'm trying to make is that you can't put a striker in the position of a goalkeeper and expect them to do a job as good as that, because how do they train? You know what I mean? Like, a striker will practice shooting a lot more than a goalkeeper will practice shooting. A striker won't be practicing saving the ball, diving, you know what I mean, in the same way. So I think it's maybe a useful way of thinking how just putting in like for like is not necessarily a useful thing to do. Just finishing off this bit as well, two things to mention. I think that something that Richard Lakeman has written about before as well is the situation in Australia is that all you need to call yourself a mental health nurse is to be a nurse working in a mental health setting. So actually it doesn't mean anything. It's like if you work in a mental health setting, you're a mental health nurse, but it doesn't mean you've actually had any specific training. But also recently, and I write about this in the paper as well, we've learned that in the United Kingdom, international nurses that might have had a generic training, so a generic nurse training, not a specialist mental health nurse training, are allowed to come over to the United Kingdom and register as mental health nurses, providing that they go through an NMC kind of competency process. I think that, again, that's quite worrying, that might be sort of genericism through the back door. So you've got people that have undertaken a generic training that's not specialist, but they are going on to a specific part of the nursing register as well. And the gripe that I would have about, while the NMC would say, and I think they have said, that people do have to go through the NMC competency processes, I would argue that kind of how robust is that competency process in terms of a specialist education for mental health nurses? How quick is that? Given that they haven't really done a service to mental health nursing through the Future Nurse Standards, and that's what this competency is sort of based on. So again, I think it's just something that we need to think about and need to talk about. Guess want to be very, very clear that this is not a dig at international nurses in any way, because the NHS could not function without that. And I'm sort of absolutely all for bringing people into the country to sort of help the nursing workforce. And I'm not a fan of sort of policies that say that you can come over here, but your family can't. Sort of just want to kind of get that in there as well. This is my gripe about this, is really about again, it being a bit of a sieve, that sieve of circumstances, these kind of decisions and policy, that allows mental health to be undervalued and kind of just sort of disappear. So that's all I've got to say about that. Right, let me try and rattle through the rest of the slides, because I'm getting tired now as well, and this is going to end up being a mammoth 2-hour podcast thing. So a nurse is a nurse. Why are we arguing that we're different? Again, I'm not arguing that we're better in any way. We're just different. Different means different, doesn't mean better or special. The philosopher Gilles Deleuze put forth the notion identities do not form and reform in isolation, but differences are actualized into specific forms of identity. So I think that what makes us unique is the things that are different, particularly the contested field and there's no shared paradigm. The answer is often, it depends. A shout out to my colleague, Sebastian, who kind of contributed that to one of the papers that we wrote. There is no sort of a clear answer in the same way that there sometimes is with physical health issues. Mental health, learning disability nursing undergo and continue to undergo seismic shifts in philosophy and approach to care. Things like trauma-informed care, the understanding of that, kind of probably wouldn't have heard of that maybe sort of 10, 15 years ago. Now it's all the rage. There's always these kind of sort of new developments and understandings. Nurses holding power, huge power dynamics, enormous potential to help and enormous potential to harm. And subjectivity and variables require an expert of not knowing. I think I've argued that before, that essentially we have to deal with uncertainty. We're uncertain around what caused the problem. We're uncertain around the best way to help. We're uncertain around how that relationship is going to develop, but we need to be able to sit with that uncertainty and not fall into any reductionist ideas of kind of the medical model, or reductionist ideas of everything's trauma. We need to be able to sit with that uncertainty and hold that expertly. And I like this meme, and again, I don't want to devalue any other sort of profession with this, in terms of talking about the complexity of mental health nursing. So I breathe air for you, I pump blood for you, I filter waste for you. So that's the human experience right there, right? Now, of course, I know that other fields will treat a person and they don't just treat body parts. But I think when we're doing mental health nursing, we are treating that human experience with a human experience most of the time. And yes, all fields will do this to a degree. But I think mental health and learning disability will do this in a much more distinct way. And what I would argue is you are treating a person's, you're treating a person's human experience with your with your own human experience. And that is incredibly complicated and requires a sort of dedicated focus. What constitutes the evidence for mental health nursing? That's really problematic, because what's the evidence base for what we do? So it can be difficult to advocate for mental health nursing when there is a kind of limited evidence base for mental health nursing itself. This paper from last year, much mental health nursing practice not supported by the highest level trial evidence, but significant findings were most likely to be identified in studies with people with non-severe mental illness. And evidence-based mental health nursing interventions have varying involvement from mental health nurses, sometimes leading, sometimes fractional involvement. So the involvement of mental health nurses within this research is sometimes kind of so small that we can't really sort of say that's ours. And a lot of the evidence isn't this kind of sort of randomized controlled trial evidence that we would sort of be looking for. So how do we kind of lead and research our own evidence base? And I think that's difficult because, again, going back to David Graeber in his theory of work, the book Bullshit Jobs, he describes the value of caring as precisely that element in labour that can't be quantified. So when mental health nursing has been successful for someone, how do you know? What are we measuring? And he argues that the value of caring is that bit that cannot be quantified. So we can see, it's usually easy to see when mental health nursing care goes wrong or is unhelpful, because we can see that people are harmed by it, and people will tell us that they're harmed by it. But it's hard to evidence exactly what happens when it goes well, or even just define what success is. I mean, like, again, it's incredibly subjective in what a person might expect for themselves and what society might expect in terms of how effective mental health care can be. So I don't think there's any agreement on that. Now, Jonathan Shedler, interesting writer about kind of evidence-based and psychotherapies, but I think it can be applied here as well. He says that evidence-based often means kind of manualized or one-size-fits-all sort of psychotherapy, and he argues about their benefits being trivial. Most patients do not get well. Even the trivial benefits do not last, because he says that the things that we're counting aren't meaningful. He says the outcomes don't measure meaningful change. So you might, and I think in some of these studies you get, person got this therapy and there was reduced inpatient stays, there was reduced instances of self-harm, but it's difficult to measure meaningful change in terms of, I had this interaction with this person, I built this relationship, and it changed my life. How do you count that in the same way? It's difficult. So I think it's difficult to identify the measure or that mechanism of change for when mental health care is successful. So the encounters with service users are always unique, untold variables, and the exact mechanism of change, for better or worse, can be obscure. And I think that makes it very, very challenging. But that doesn't mean that we shouldn't try. And I think we do need to try. So again, sort of building on some of that unquantifiable caring bit, is there a complex simplicity to helping? So a skill to doing simple things in a complex world and complex system. Because actually, like, a lot of the time when you say to people what do you want from a mental health nurse, it's often actually quite sort of simple things in terms of, I want to be respected, I want to be valued, I want to be treated as a person, I don't want to be treated like a diagnosis, I don't want to be stigmatized. It's kind of things that you would sort of think, okay, why aren't we sort of just doing that every day anyway? But something I've kind of sort of found through my PhD as well is that actually sometimes these simple things, they might be more difficult to do because of all the complex factors around them. So you're not actually working in these really difficult environments with lack of certainty, lack of autonomy, maybe for kind of mental health nursing, sometimes trauma experienced by mental health nurses. Sometimes these things actually get in the way of the simple things being done. This was a good paper talking about service user experiences, wanting people to meet me where I am. Saying quite often there's a fear of talking to a consumer. So people experiencing mental health problems and encountering mental health nurses who seem scared to kind of talk to them. And again, I think you go into any conversation, you never know what's going to happen. Again, there's a massive amount of uncertainty. And what I've noticed teaching student nurses over the last few years is that they're always looking for that single right thing to say, which doesn't exist. There is no single right thing to say. I could list you a big list of wrong things to say, but there's no one right thing to say. So there's a requirement of your kind of your own congruence and stuff like that. You know what I mean? Your own personality, your honesty. And you could say something that would be completely unique to you, but it would be valued in that sort of scenario. So this searching for the one answer might actually get in the way of good care occurring and people being scared to talk to people. And that's why I think that we need to be very, very careful about the relational skills that we're given mental health nurses, because they will be having conversations with people with complex problems, and we want people prepared appropriately. They should be trained from the start to encourage the personal touch. So, and then again, how do you sort of balance that with all the rhetoric in nursing about professionalism? You have to be professional, and service users here are wanting the personal touch. And I think that's difficult. And I think that actually sometimes this need to be professional and probably for me, a mistaken sense of what professionalism is can actually lead to distance in relationships rather than that kind of closeness. And again, it needs a long time to sort of talk about. It needs depth of education to be able to understand these relational skills. There's different techniques. It's important that they learn many of them. If it doesn't work, try something else. So we need people to have a kind of suite of interventions, you know what I mean? Like that toolkit that people can have a variety of different things that they can call on. And you can feel that really soon if your doctor or your nurse think that you're a hopeless case, but you can also feel when that person has hope for you, even though you don't have it yourself. And just knowing that hope is incredibly important. And again, I don't think that's a simple thing. I think having hope for people in a complex world, in a complex system, is actually something that requires a kind of preparation. I don't think that it's something that people just have or don't have. I think it's something that needs to be kind of talked about. And just a couple of things that I sort of took from my PhD here as well that I really liked. So Billy, a mental health nurse, and these are all kind of pseudonyms, on understanding as an intervention. Genuine came in not knowing what to do with Carol, so just wanted to understand. The more I've tried to get it, the more she's been able to get stuff out and make connections to things and also feel safe. I think that's what she needed. But actually, just understanding someone, that active listening, takes skill, you know what I mean, to sort of listen and absorb that and listen to difficult experiences of trauma, of sort of incredibly complex experiences of mental health that we might not readily understand. So you're actively trying to understand. And if a person really feels understood, that can be an intervention in itself. That can be incredibly validating. And nameness, authenticity, and congruence. And Carol saying she described a mental health nurse and her Julietness, again, sort of all pseudonyms here, but that sense that there's something unique about you that people will value. They'll value that honesty, that congruence. So what you're getting just now is my Danness through doing this. Whoever you are, what's your name, your nameness. That's the thing that people are looking for. Okay. Let's try and finish this in the next 15 minutes and round it up to 2 hours. You can pause whenever you want to. I'm just tired and I'm wanting my tea. So what might society need from a mental health nurse? Again, this is a starter for 10 from me. I think I've been moaning about the situation for mental health nurses for quite a while. Maybe I should sort of offer some kind of suggestions and some ideas that I might write about at some point. So here's my list. Understanding the contemporary world and how this may impact mental health. So there's a sense of kind of knowing where you are in the world, in human history, what's going on, how is it impacting the way people might feel. An excellent self-awareness, being aware of a personal world that comes with you and how it impacts your behavior and relationships. You know what I mean? I'm not for this kind of idea that you sort of leave yourself at the door and then you go and kind of be a professional. You take yourself with you wherever you are, and you need to understand that stuff. A deep understanding of ethics, human rights, and use of legislation. If you're going to have enormous power over people, you need to have a responsibility to use that power appropriately and think about that. So we should be having conversations about ethics, human rights. We should be talking about these things. And I didn't hear those things sort of talked about like I hoped I would when I was sort of practicing in an inpatient unit as a mental health nurse. We don't talk about is this ethical, is this unethical, but I think we should. Excellent relational practice, high-level communication skills, emphasizing nameness, that unique nature of yourself, duty of candor and transparency. Understanding mental health interventions, the evidence base and the limitations of that evidence base, like I was kind of talking about as well. Advocacy skills, which can help people navigate a complex health and social care system. Some of this came from the original Chris Connell et al. Paper on mental health nurse identity that was out 2021, 2022, that talks about that need to advocate for people in this kind of complex mental health care system, where actually you might actually have to recognize that this is a system that can hurt people. This is a system where people can feel voiceless and they can feel that they don't have a say. And you might need to be that voice that stands up for that person. That might be actually standing against your colleagues, or it might mean standing against other people in the multidisciplinary team at points. And that obviously makes it relationally complex between mental health nurses and colleagues, as well as with sort of service users. A focused understanding of common physical health issues that relate to mental health, and I'll come back to that focused understanding. And political skills and understanding how to influence change at micro and macro levels. I would argue that because it's so complex, because it's such a contested field, we should have people that are able to present an argument. This is why I think this, and these are my reasons for thinking this, and I'm willing to listen to you, and I'm willing to have my mind changed. And actually, I want to have my mind changed, but if it's not changed, I am willing to stand up for myself, and I'm willing to advocate for my position on this. So that's my starter for 10. Now, is holism possible? Just a dig at this kind of holistic thing. Now, holism's never defined by the NMC, and I think that that's problematic when you're going to say something's holistic. But well, tell me what you mean by holistic. Tell me what you mean by holism. Now, this is from a paper 2017. Holistic care defines a comprehensive style of care in which patients' entire needs are addressed as a means of enabling full recovery. So I worry about that sort of sense of meeting a patient's entire needs. I mean, what do we mean by that? And is any nurse able to be that one-stop shop? Like, because I think this is a problem as well, isn't it? So services are often set up to be specialist. So how does that holistic practitioner fit into a specialist service? So even assume, let's take sort of play devil's advocate for a minute and say that the future nurse standards are amazing and everyone's going to be trained in all these things. Everyone's going to be able to do everything. But people are still going to go into environments that aren't generic, that aren't necessarily holistic in that way in terms of meeting everyone's needs. They're still going to be going into specialist environments. And I would argue that actually achieving holistic care, it's not achieved by individuals not being specific, but actually might be better achieved by an integrated service. You know what I mean? So where actually you've got multidisciplinary team, where maybe even you've got nurses from different fields working together. I think that's maybe a better way of achieving holism than trying to get everyone to do everything. Again, I just don't think it's possible. And if we were to say we want a person's entire needs to be addressed, where does that end? Where do you draw the line with that? Do you get sort of the next iteration of Future Nurse Standards and they've added in hairdressing and dentistry because we want to address, and hey, if you can do it, do it. But I just don't think it's possible for people to learn all these things and then be able to do them all well. I don't think it's possible. And what I'm arguing here is like, is any nurse able to be a one-stop shop? No, but it sure looks good. And we've got 235 proficiencies here in the Future Nurse Standards, skills and procedures for any nurse to know and be capable of doing safely and proficiently at the start of their career. I think that's a big ask of people to learn all these things and be able to kind of rattle that out the bag when perhaps they've had limited exposure to it throughout their training, particularly when they're in placements that might not afford that experience. And I am cynical that this becomes box ticker work. And again, going back to the ideas of David Graeber, he says box ticker work exists because within large organizations, paperwork attesting to the fact that certain actions have been taken often comes to be seen as more important than the actions themselves. So my cynical take on this is that this is the illusion of holism in place of specialism, and without actually creating this future nurse that is amazing, the NMC can still say they've created this future nurse that is amazing. And yeah, keep calm. It's holistic. I think that's sort of been some of the response from the NMC that I've written about in the paper. So less is more. This is me coming back to the physical health kind of issue. So the NMC standards have been argued to try to be all things to all people all at once. And again, don't think it's possible. And this was argued in kind of 2015 before the Future Nurse Standards were actually out there. The common sense argument that generic training will upskill all nurses is easily countered by the claim that it leads to the unskilled jack of all trades. So are you upskilled or are you unskilled? And certainly I'm arguing that, are we upskilling or are we simply diluting specialism? And I think what we've done is diluted a specialism here. And I guess I'll use this sort of Bruce Lee quote here, which I really like. I fear not the man who's practiced 10,000 kicks once, but I fear the man who's practiced one kick 10,000 times. So shouldn't we aim to be very good at less instead of having a vague idea of how to do everything? Again, like I think sometimes there is that like less is more. The more you try to cram in to an education, probably the less people will retain. And the less depth you will achieve, certainly. So I don't think that we should be ignoring physical health, but I think we should be very good at the most relevant physical health to the job. And we should be sort of looking at that and discussing that and saying, what are the things that we really, really need to focus on? Because I'm damn sure it's not blood transfusions. And primarily, doing what it says on the tin, being highly skilled and knowledgeable around mental health. And I think there is that bit of like, if you're going to have a mental health nurse, then surely that should be the priority in their education. That should be more important. That should be addressed throughout the training, that you shouldn't have mental health nursing as an afterthought within a university education. It should be built from the ground up, not sort of squeezed and marginalized. Almost there. So mental health deserves better. Resistance, assertion, creation. Now, I think I've argued, I mentioned this already, but it's in the paper as well. I think the Nursing Midwifery Council are a government without an opposition. And universities are a lottery, and quality assurance of courses is inadequate at present. I know that actually at this present time, there is a sort of new setup for quality assurance. So fingers crossed that that is going to improve. But certainly up until now, I think that's been inadequate. And there's been no real accessible channels for many in mental health nursing. And we sort of needed to create a space with a voice. And that's really what mental health nursing has sort of has become is a space where mental health nurses and nurse academics can come together to talk about the issues that are facing them as a profession, actually talk about how we might sort of try and shift the dial and move things forward. And the aim of the group is to forward the profession of mental health nursing to best meet the needs of the population. Now, anyone can join and anyone can use the space and network. Now, hopefully that QR code still works, but if not, yeah, I mean, people can sort of contact me, and the email address is at the end of the kind of presentation as well. And the group actually has had some impact already, I think, with some kind of shared publications, with the open letter. And actually, we've heard that within some universities, there has been a sense of acknowledging the shared feeling within mental health nursing, and more mental health nursing has started to creep back into a lot of courses that are being kind of revalidated. I still think there's a long way to go, but this has been a useful space and platform, and I would still encourage more people to join if you're interested. So is this the last stand of mental health nursing, or is that a kind of step forward? Now, the last stand, I don't think like we can say this is the last stand of mental health nursing. I think there's been many sort of stands before, and there will be again. And it's interesting, like anything that I've said in this recording, anything that I've said or written about over the last kind of 3-4 years has been pretty much written about in the kind of 20, 30, 40, 50 years before me. This problem keeps coming back. But I wonder just now, are we even standing, or is the profession now a bit of a kind of cardboard cutout? So mental health nursing in name, but with sort of none of its own kind of philosophy or substance. Is it a bit of a PR exercise of saying mental health matters? Yeah, we've got mental health nurses, but we've got people coming from overseas that don't need a mental health nurse registration or education prior to registering as mental health nurses. We've got a genetic underpinning that we don't have specific standards for these mental health nurses. You know, there are loads of kind of problems around this that doesn't necessarily protect it. So is it this cardboard cutout rather than anything sort of meaningful? But maybe kind of beyond sort of actually standing up for ourselves, which I think we still need to do, can we try and walk forward, imagine, and create a future? And it's important that we don't assume others will do it. I never expected to be in a position where I'd be writing about mental health deserves better and all this kind of stuff, and folk would actually be sort of listening to what I said. But it sort of feel a little bit of a sense of an obligation to kind of keep it on the radar, because I think it'll quickly drift into obscurity again, because everyone's so busy all the time and it takes a lot of energy to keep this going. So I would encourage anyone to, like, if you actually care about this, then have a go at doing something with it. You know what I mean? Stand up for the profession, stand up for yourself, and stand up for what you believe in, and creating, not waiting. And there's a lot of things that we could be considering when we're moving forward. You know what I mean? For example, the midwifery model, you know what I mean? They are respected as a distinct kind of profession, you know what I mean? Nurse and Midwifery Council, but midwifery often has its own course. It's called its own thing. Is that something? Again, I come back to this point that needs to be discussed. Does mental health nursing need to leave nursing? Has nursing become so sort of stereotypical around the adult nursing thing that does something new need to appear from the ashes? You know what I mean? That idea of the sort of the phoenix that burns out and is then reborn. Does that need to happen? I don't know, but we need to be talking about it and thinking about it and trying to move things forward. And we're almost at the end here, almost at the 2 hours. Here's your bonus content. So this is the original tweet that got me in trouble from a couple of years ago. On April Fool's Day, I said, received an email from the NMC this morning saying they now understand the complexity of mental health nursing and apologise for the dilution of mental health nurse education. They've agreed they deserve our own bespoke education and will mandate this across the UK. And then about an hour later, just to clarify, this was indeed an April Fool and not a funny one, as it highlights the sad reality that mental health nursing students often don't get enough mental health in their education. This needs to change because people who receive mental health care deserve better. And hopefully you found that amusing. Somebody, I remember, commented, thought it was a clever way of drawing attention to the issue. But the NMC had contacted the university at the time. They were unimpressed, asked for a report, and the university gave me in lots of trouble for it. So different senses of humour in the world, again, emphasising the subjective nature of human beings. And that's me bang on at the 2-hour mark. Honestly, thank you if you've got to this point. I never expected it to take this long. I've just kept speaking until it's done. You can contact me at any of those sort of email addresses, my own personal email address and the Mental Health Deserves Better movement email address as well. The QR code should take you there as well. I've got references here as well that you can look at, pause if you want to kind of have a look at them, and I'll also put a link to the presentation slides in the description for the video as well. And I'm going to stop sharing now, and thank you very much.